Okay, good morning. So thank you very much for giving up your Saturday morning to come and hear about radiation therapy. So my name is Michelle Leach and I'm head of radiation therapy in this university. So when we talk about radiation, it can conjure up to the general public, it can conjure up quite a number of different ideas about what radiation is. Some people are kind of inherently afraid of radiation because they obviously think of things like nuclear power plants and the like. Unfortunately, I think our career is probably not as glamorous as this one, but what it is the use of ionising radiation to treat what we call malignant disease, or what we call in the general population as cancer. So one of the first questions potential students usually ask us is, what is the difference between radiation therapy and what's known as, in some British universities, as therapeutic radiography? And the answer is there is no difference. Okay, so we just use the title radiation therapist, which is recognised by our European Professional Society, ESTRO. So we're known as radiation therapists, or RTTs for short. In Britain, people are still called therapeutic radiographers, but it's the same profession. That's the first thing to say. The next thing then students usually ask us is, how is this different to diagnostic, or what we call general radiography, or radiographers? And I suppose the first thing to say is that we actually are part of the same professional body, and that's the website of our professional body if you're interested. So it stands for the Irish Institute of Radiation of Radiography and Radiation Therapy, IIRT.ie. And we're historically part of the same professional body, even though we are actually quite separate professions. And the main differences in the work that we do are, firstly, the patients that we see and the patients that we treat. So obviously, radiographers see a wide variety of patients with, many different pathologies. So some trauma patients, your usual, I have to go for a chest x-ray, I have a CT, an MRI, and so on and so forth, whereas we specifically see cancer patients. Now, there are some very rare occurrences where we use radiation therapy for benign or non-cancerous treatments, but they would be extremely rare. So our patient population are cancer patients, and all sorts of cancer patients, from children up to the quite elderly. The other main difference is the type and quantity of radiation that we use. So if you're going for a CT scan or for a chest x-ray, the radiographer is going to use quite a low level type of radiation, so called kilovoltage, so low quantities of radiation. That obviously have to still be minimised, because any amount of radiation, as you know, is quite dangerous. Whereas for treating cancer, we have to use a much, if you like, larger quantity and much stronger type of radiation called megavoltage. So if you're good at maths, you can do your kilo to mega and see that we're talking about 1,000 times as strong, if you like, radiation as you'd use in diagnostic imaging. So there, I guess, the main differences. Another thing to point out is that as radiation therapists, we actually use low energy x-rays quite a lot ourselves to plan a patient's treatment, and to also take images daily to make sure that patients are in the correct position for treatment. Because you can imagine, if you're a patient with cancer, say a tumour of your head and neck, you're quite likely to not be able to eat and lose weight over a period of time. So we have to keep making sure we're treating the same area every day. So we treat it to millimetre accuracy. So that's what it is. So the terms radiation therapy and radiotherapy are interchangeable. So sometimes, even during this talk, I might say radiotherapy or radiation therapy. We use them interchangeably. So it is a specialised branch of medicine that's concerned with the treatment of cancer. So what is our goal? Our goal in radiation therapy is to treat the cancer cells, so to really target and focus our beams of radiation to the target cells, while keeping the dose to normal cells as low as possible. And that is really one of the most difficult things to achieve in radiation therapy, because radiation is not selective. It's not going to know this is a cancer cell, this is a normal tissue cell. It's not selective, so it is going to kill both of those cells. And when we kill normal cells, then the patient ultimately ends up with side effects. Okay, so that's our ultimate goal, is to treat the tumour and to keep the dose to normal cells as low as possible, so that patients will have quite a good quality of life. One of the most important things, I suppose, when you're considering this as a career, is that yes, it is a very technical job, you know, and the technology is always advancing every day in radiation therapy. The vendors are coming out with more and more sophisticated equipment and machines and things for us to deal with. So we are, you know, that is obviously extremely useful to try and minimise the dose to normal tissue. But one of the main things as a profession that you have to remember is that when we're looking at a tumour and we look at scans and so on and so forth, those scans are of a person, you know. So cancer resides inside a person. It's not just a tumour that you see in a CT scan and you're completely focused on that. So in this undergraduate programme, we're always extremely focused that the student will always keep in mind that the patient care aspect of this career is extremely important. We don't work in isolation. We work as part of a multidisciplinary team, which if you listen to other talks throughout the day, nearly all of us in health sciences do. Our team, I suppose, are in certain ways quite specialised. So we'll include the oncologists, so the surgical, medical and radiation oncologists, who are the consultants whom the patient will see first of all. We work closely with medical physicists because we have to calculate doses of radiation. We have to make sure that our treatment units are delivering the doses of radiation that we've calculated. Otherwise, we cannot, you know, legitimately tell a patient they're likely to be cured if these machines are not calibrated correctly. And we also work with our colleagues in nursing. So we plan and deliver these radiotherapy regimes for patients. We are the main contact person for the patient during the course of treatment. So another, I suppose, difference between diagnostic radiography and us is that we can see the same patient 5 days a week for up to 7 or 8 weeks treatment. So in that way, that's why the patient care aspect is so important. Because, you know, maybe some of you in this audience have been affected by cancer or know someone or have someone in your family who was affected by cancer, and it's a time in patients' lives that is extremely traumatic. So you have the opportunity to build up, you know, a very good relationship with a patient and to help them through this difficult period. And that's quite a privilege, to be honest. So we have a look at some of the work that we actually do. So these are just some images from pre-treatment processes. So you can imagine that this patient is not a patient, it's actually a student, a volunteer, who is being treated for a tumour of the head and neck region. So we have to immobilise or keep the patient steady when we're treating them. Okay, so if you're treating with sub-millimetre accuracy, people cannot be moving. So this probably looks quite a lot worse than it actually is as an experience. So this is called a thermoplastic mask. So it comes in flat sheets of thermoplastic and we heat it up in a water bath to a certain temperature, and then we mould it to the contour of the patient. So this is a 4-point mask, so it fits in here, and on the opposite side in the same points. So this would be one part of pre-treatment work for head and neck cancer. This is another one. It's making a different type of mask from a plaster of Paris. So it's the same as if, you know, if you broke your hand or your wrist, that kind of plaster of Paris. It's a more difficult procedure for a patient because it gets actually quite warm inside those. So what happens with that is that eventually it looks like this when we've made it, and then there's a little bit of artistry involved to create a bust from this, and then to create this different type of plastic mask, a perspex mask from that. But it holds the same purpose as the previous one, to immobilise the patient. And a second function of these devices is to obviously add some marks to the mask so that the radiation therapists know where to direct the treatment beams. Okay, so this is for a head and neck patient. For other sites in the body, so for other, say if someone had a breast cancer or prostate cancer, we would use tiny little tattoos that are literally like the top of a pin to help us set patients up for treatment, so to mark them for treatment. So they're external marks, but we obviously use imaging to check the internal anatomy as well. Another area that you will work in as a radiation therapist is a very important area called treatment planning. And this is a full module on this program. And on this, in this area, we take images of our patient. So again, the diagnostic quality images. So this is just a single slice, axial slice down like this through a patient who has prostate cancer. And what these lines here represent are the beams, the angles that the beams are going to come from to treat this red area here, which is one slice of prostate and seminal vesicles in a male. And we're going to have decided that to treat this patient, we'll bring a beam this way, so from the front, anterior, and one beam from this side and one beam from that side, so 2 lateral fields. And that's a process called treatment planning, where we decide upon what is the best beam orientation for the disease that we're about to treat. And we have to do a lot of optimization to make sure that these other lines that appear around here are representing doses of radiation. Can you see? Very small there, but that's representing percentage dose of radiation. So we have certain, obviously, very stringent guidelines that the tumour has to receive a certain dose, and that critical structures or normal tissues, or organs at risk, as we call them, which in the case here would be the rectum and the bladder, and also the heads of the femurs or the hip bones, are receiving a certain minimal dose, so that it won't impact negatively on the patient's quality of life. So even though it's quite technical when you're working on something like this, and this is what is taught in this program, your mind is always to, how will this affect this patient? Okay, so it doesn't matter how lovely it looks on your screen, as I tell students, it's how is this going to affect this patient at the end of the day. And this is what a treatment unit looks like. So these treatment units are called LINACs, or linear accelerators. So they're obviously quite expensive machines, a few million euro. So they are comprised of a main kind of area here called the gantry, and this round area here called the collimator that rotates, and this can rotate all the way around this bed, and the radiation beam will come out through here. Okay, and then in this room as well, we have lasers fixed to the sides of the wall to help us align the patient correctly. So the bed or the treatment couch that the patient lies on looks very uncomfortable, and unfortunately it is. It's also extremely narrow, as it has to be for this to rotate all the way around. So what kind of a person do you need to be a radiation therapist? You really need to be multi-skilled. So you need to be, sometimes we call it a bit of a perfectionist. You have to be someone who is accurate to the millimetre. That's really important. But you also need to be a kind of a people person. You need to have a personality to help people through such a difficult time in their lives. The degree of technical knowledge, I think, is what attracts a lot of students to this career, and of course that is really, really important. But when you're treating a range of patients from children, which is extremely difficult for most people, right up to people your own age, to people the same as your grandparents, you really do need to have excellent people skills. And you also have to have, I suppose, quite a good coping strategy for working in this profession, which we do obviously help you with during the programme. So I suppose now down to the nitty-gritty of what you will actually learn and the course content. So this is a 4-year honours science degree, so there is a significant scientific component to it. And many of our graduates, most of our graduates work as radiation therapists, but some of our graduates will also work in other areas as scientists. Some will go into physics, some go into medicine. We've had a meteorologist once upon a time, so we have quite a variety of different professions, and because we have it's an underlying science degree at the end of the day. So in first year you will study physics, radiation physics, obviously, chemistry, biology, anatomy, and we have a really nice way of teaching anatomy with our new facilities down in TBSI, where you might have been earlier on Pearse Street, in the anatomy department. So we were able to teach what we call cadaver anatomy with bodies, as well as cross-sectional radiographic anatomy at the same time. So first year anatomy is thorax, abdomen and pelvis. In first year as well, you're introduced to a module that's really critical to this degree, called Principles and Practice of Cancer Care. So that's all about how cancer comes about in the first place, the genetics of cancer, how you might decide to treat particular patients, why some patients have surgery, some have chemo, some have radiation, some have combinations, and so on and so forth. And that module underpins this entire degree throughout the 4 years. And we start with Psychology and Communication 1 as well. It's extremely difficult to, and we appreciate that, to come, as most of you will be, just coming from school, to come into a hospital environment, and particularly into a cancer hospital environment. In second year then, the anatomy continues being taught in the same way, but this time we focus on head and neck anatomy and neuroanatomy, so anatomy of the brain and spinal cord. You'll study physiology, biochemistry. We continue with psychology and communication. We use quite a lot of role play in that year, which is very useful, I think, for students. We continue with radiation physics, principles and practice of cancer care, and I think as well to point out with this degree, research is a really fundamental aspect of this degree as well, and you'll be certainly extremely well equipped to perform research, whether you decide to be a radiation therapist at the end of the day in your department, or whether you want to go on to do something else as a scientist. So we start with research methodology and statistics in second year. The third and fourth years then consists of an in-depth study, instead of going through all the modules again, of cancer and its overall management. And that includes things like imaging, using imaging for ensuring a patient is correctly set up every day, what imaging you use to define the tumour on the patient and the normal tissues, how you orientate the beams and calculate doses. Your own self-development is very important, and how you, in the third and particularly coming towards the end of fourth year, how you are learning to become an autonomous professional, health professional. Because it's quite different from being a student to making that leap to actually working. And healthcare management is also part of this, and we have an evidence-based practice project on that aspect. And you have to complete a dissertation or a research project in a related area, and that related area has to be in line with our research group, which is Applied Radiation Therapy, Trinity. So for clinical placement, we have a state obligation to have a certain number of hours clinical placement. So that is 40 weeks in total over the 4 years. So the bad news is that in all health sciences, the holiday periods tend to be short, because a substantial amount of clinical placement does take place in the vacation time. And that's particularly in the third and final years, particularly that summer between third and fourth year. The clinical placements are, I suppose, shorter in the freshman years, as we try and build up your knowledge about cancer. Because this degree is not about, rote learning, going out on placement and learning how to set someone up for treatment. It's about why you're doing what you're doing, how you problem solve, and how you look for errors, which is a very important aspect of this profession. So there's significant clinical placement in the sophomore years. For example, our current fourth years now will start in January on placement for 5 months. And one thing to be aware of, and if there's parents in the audience to be aware of, is that students are placed in departments in various locations throughout the country. So we use our private centres as well as public centres to accommodate our students, because some centres have different equipment to others, and we really need to get a good understanding and have a good experience with all of them. So in such cases, unfortunately, those costs are borne by the student, or in most cases borne by the parents, of course. So the radiotherapy departments in the country are, there's obviously quite a substantial number in Dublin. There's one in Cork. Then the private centres that we use, there's one in Whitfield, in Waterford, the Galway Clinic. There's a public centre in Galway. That's about it. The other private ones are in Dublin. So we use quite a varied amount of assessments. So I was particularly happy to hear that they're changing the junior cert and moving away from exams. So we have a certain number of exams in this course, but we also have a lot of different ways of assessing students, because obviously your academic performance is important, but also your performance in terms of how you work in groups, because we always work in groups, is equally as important. So we have a lot of group projects, which is a little bit alien to students coming from the Leaving Cert, and it can be quite difficult in the beginning to learn to have to change, I suppose, your method of learning. You are required, obviously, to pass all assessments in both the theoretical and the clinical areas over the 4 years. You have to complete your clinical component within the academic calendar year before you can rise with your class or move to the next year. So we have a lot of projects, we have a lot of practical assessments that students seem to like as much insofar as students like assessments, and continuous assessment, which takes a lot of pressure off students then towards the end of the year. By the end of 4th year, you have a very substantial clinical portfolio built up, and the thesis or dissertation they're the main assessment processes really in the final year. Your degree award is calculated on your performance in both sophomore years, so in 3rd year and in 4th year. So that's in line with a harmonisation process in this university. So your first 2 years you have to pass in order to progress throughout the course, but the awards that you will get at the end of your degree, so what mark, if you like, you get in your degree, is based on your performance in both 3rd year and 4th year. So the career opportunities, which of course we have to talk about, particularly these days. Unfortunately, I guess there's always going to be jobs in a profession such as this, unfortunately in some ways, because cancer obviously is rising we have an increasing ageing population in this country, so we see quite a lot of new cancer cases every year. So radiation therapy has expanded rapidly throughout this country. So we have, in the last few years, we have new centres on site at St James's Hospital and Beaumont Hospital that are part of the St Luke's Radiation Oncology Network. So we have, I suppose, very good prospects for future graduates in this country. Should graduates wish to travel, which obviously a lot of graduates do wish to travel, then this qualification is recognised worldwide and is kind of seen as a benchmark against which others compare themselves to. The majority of our graduates, as I said, do work in this field, and those who choose to, on their last placement now going into 4th year, many of our students will actually have secured employment before they graduate, obviously pending passing their exams, but that would be kind of a standard, that would be kind of standard in this profession. So just, I suppose, some facts and figures for it might be of more interest to your parents. So I don't have the figures from last year, sorry, but they're pretty similar anyway. So of the 2012 class, and we have small class numbers, I have to say that, we'd have about 30 per year. 3/4 of them are employed as RTs in Ireland, 12.5 are employed in a health-related field, and then others are in further education, and others are working abroad, which they chose to do. Of the 2011 class, around the same are employed here in Ireland. 16% are still radiation therapists abroad, 4% in further education, and 4% are abroad employed in doing something else. So we have come up, I guess, because of the 2010 class, 61% were employed as radiation therapists in Ireland. So I think our stats are quite good. That jump, I guess, between 2010 and 2011 was when the new centres had opened in Beaumont and St James's. The other thing I suppose to say in career opportunities is that it's quite a female-oriented profession in this country, actually, interestingly enough, not in other countries in Europe. So we always have quite a lot of radiation therapists on maternity leave. So a lot of our graduates may start off covering a maternity leave contract, and then they end up just getting a permanent contract.